Let's look now at polycystic ovarian syndrome, which is really a continuation of this topic. Here's our case. A 32-year-old complains of vaginal bleeding, facial hair growth, and obesity. Facial hair growth has been present for many years, so it's unlikely to be a tumor. But it's getting worse during the past 6 months. On pelvic exam, she has slightly enlarged bilateral ovaries. Have you heard of the Heron syndrome? HA stands for hyperandrogenism, IR is insulin resistance, and AN is acanthosis nigricans. Heron syndrome, a multi-system challenge. For many years, internal medicine physicians really didn't have much interest in PCOS because it was thought to be just a gynecologic disorder with enlarged ovaries and infertility. Now we recognize that with insulin resistance, with the increase in type 2 diabetes, cardiovascular disease, in coronary artery disease, this is something that we need to look at for a lot of reasons. And it appears that maybe the underlying focal pathophysiology is insulin resistance. This is what leads to hyperandrogenism because insulin levels high stimulates testosterone production by the theca cells in the ovary. And the acanthosis nigricans is also a function of insulin resistance. So if we can lower the insulin resistance, you can do a lot for these patients. This is acanthosis nigricans in the axillary area, in the neck, and here you can see in the axillary area as well, often described as a velvety pigmentation. The definition of PCOS is a condition of chronic anovulation resulting in infertility, irregular bleeding, obesity, and hirsutism. At least that's from the gynecologic standpoint. When we look at the pathophysiology, we have chronic anovulation leading to infertility. We have increased testosterone leading to hirsutism. And we have enlarged ovaries, which lead to the polycystic ovaries. How does this occur? Chronic anovulation is a result of steady-state LH, which is increased over FSH. The LH being steady-state elevated never surges, so you don't have any ovulation. So we have lots of estrogen, but no progesterone. If there's no ovulation, there's no corpus luteum, unopposed estrogen, and we have bleeding, and ovulatory bleeding. The elevated testosterone comes from two sources. One is increased production because of the increased LH stimulation of the theca cells. The other is there is decreased sex hormone binding globulin. And this is because of decreased liver production from the increased androgens. So we have increased production and decreased binding, which leads then to increased free testosterone. The elevated ovaries, the size of the ovaries, are because of the many multiple peripheral cystic follicles, which are fail to mature because of the increased androgens. So we have enlarged ovaries from multiple cysts, stromal hyperplasia, and a thickened capsule. What's interesting is that a lot of women who have epilepsy, seizure disorders, and particularly women who are on Depakote will develop PCOS, and their etiology is not entirely clear. So chronic anovulation, we have a steady-state FSH, steady-state estrogen. If you don't have a rise in estrogen, we just talked about that, no LH surge. If there's no LH surge, we have chronic anovulation. If you don't ovulate, there are no eggs, you're infertile. Management. Historically, it was to use clomiphene, which would stimulate the release of FSH, which would then lead to hopefully a rising estrogen. Now we realize if we can deal with the insulin resistance by giving metformin, that can also assist in ovulation. If there's no LH surge, there's no corpus luteum. If there's no corpus luteum, there's no progesterone. If there's no progesterone, we have unopposed estrogen, irregular bleeding. That has been traditionally dealt with progestins, but if we use oral contraceptive pills, we will not only stabilize the endometrium, but we'll also suppress the androgens with the testosterone and hirsutism. The increased androgen production is because of an elevated LH over FSH. The LH is higher. We have a steady state LH. The LH stimulates the theca cells. Interestingly, the insulin also stimulates the theca cells. There is increased production of androgens then. So we have increased free testosterone from the increased production. The androgens will suppress liver synthesis of sex hormone binding globulin. You put those two together and we increase the free testosterone even more. And of course, that leads to the hirsutism. So how do we deal with this? Where oral contraceptives can be very helpful because the oral contraceptives will decrease the LH, it'll suppress the LH so we have less production. The estrogen in the oral contraceptives will stimulate the liver synthesis of sex hormone binding globulin. So we have decreased production of androgens by oral contraceptives. We have increased liver synthesis of sex hormone binding globulin, so we will decrease free testosterone. Now, if you decrease testosterone too much, it may decrease the libido. And about 15% of women on estrogen-containing oral contraceptive pills will have decreased libido. So that's always something to keep in mind. Now the enlarged ovaries. And you can see the significant enlargement of these ovaries on this patient. It's been described as a necklace of cysts around the periphery of the ovary. And here's an ultrasound that shows it very nicely. The ovarian enlargement has etiologies from the steady state FSH, which increases follicle stimulation, but the increased androgens causes premature follicular atresia, so you don't have the completion of the maturation. So you have many follicles in various stages of growth and atresia. What causes enlarged ovaries then? It is these multiple follicles which never reach the corpus albicans state, stromal hyperplasia from the production of androgens, a thickened capsule, and we have the enlarged ovaries. The diagnosis is suspected historically by infertility, irregular bleeding, obesity, and hirsutism, and confirmed by an elevated LH-FSH ratio. It should be 1.5 to 1, but it is elevated 3 to 1. How do we manage it? We've already talked about this. Progestins can prevent the endometrial hyperplasia and irregular bleeding, but oral contraceptive pills can also do that. And oral contraceptive pills not only can stabilize endometrium, but can also lower the testosterone by decreasing LH and increasing sex hormone binding globulin. Spironolactone, we already talked about this, can decrease 5-alpha reductase enzyme activity and can then lower the dihydrotestosterone level in the hair follicle. Infertility we'll talk about in just a minute. Clomiphene induces ovulation. Metformin enhances ovulation because it reduces the insulin resistance. So our management will depend on whatever the predominant problem is. Is it irregular bleeding? Is it hirsutism? Is it infertility? But you can see oral contraceptive pills are very central to this. Metformin as effective as clomiphene in PCOS. And no defects in terms of birth anomalies. So we actually continue the metformin through the pregnancy of these women. And that's the end of polycystic ovarian syndrome.